This is an orthokeratology patient where we're getting a little bit of undercorrection as well as some unresolved cylinder in the patient's post-wear refraction. If we look at the topographies, we can see that the corneas are pretty flat centrally. This is a fairly flat cornea to begin with. And so we're getting pretty good central applanation. The lens looks like it does ride up a little bit higher sometimes in both eyes, and that could be contributing to the patient's visual complaints. Another thing I noticed by looking at some of the other topographies is that the patient's tear film doesn't look that great. So I think there's even a chance that just by improving the patient's tear quality that uh, the vision will improve. And so I would recommend just doing aggressive artificial tears and hot compresses if there's anything going on with the eyelids, and possibly even artificial tears inside the lens prior to lens application. I like to use non-preserved products for ortho-K patients, so Refresh Plus or Optive Sensitive or something like that. And even inside the lens, for patients who have difficulty with quick breakup times, I will have them put Soluvisc inside the lens and apply the lens almost as if it were a scleral to trap some of that solution underneath. I don't always use it long term, but to help with integrity of the tear film, I will put patients on that for a few weeks because I think if we can improve the quality of the tear film, we will improve the patient's vision, and we may not even need to make any big changes to the lens. If I bring up the lens that the patient is wearing right now, we can see that it is a freeform lens. The blending is turned off, and we have a fairly flat base curve because the initial Ks are pretty flat. If we look at the over refraction, Wave predicts that if we mold out all the patient's cylinder, that the patient will end up with about a quarter diopter against the rule. So the post-wear refraction shows that we're getting a diopter with the rule, so even more than what's in the pre-treatment refraction. So we are inducing cylinder into the lens. Again, I think some of that could be tear quality issue, and I would address that very aggressively first. If we do want to make some changes to this lens, I would go back to a GSIM design. And the main reason for that is the initial topographies that we're using for the lens design were a little bit jagged if you look at the photo process view. And when we're designing a lens in freeform mode based on topographies that are possibly more representative of a asymmetric tear film as opposed to an asymmetric cornea, we can kind of trick Wave into creating a lens that we don't really need. Another thing I would recommend for any patient that you do use freeform lenses for is to have the lab dot the lens at the 6 o'clock position so that we can ensure that the lens is oriented the way we want to. A freeform lens that is not orienting exactly the way we expect it to is not only going to not give us the results we want, but it will actually make what we want a little bit worse. So I do have the lab dot the lens and also add prism ballast so that we know for sure that the lens is sitting the way we want it to. As far as the potential lens change, I would go back to a GSIM lens and I would turn the blending back on. I think that helps a little bit with centration of the lens. The lens is sitting a little bit high at times. And I would go a little bit larger too. I think we can go 11.1 or even 11.2 on this patient. That will help stabilize the lens. I would increase the demand a little bit, flatten the base curve so that we get a little bit more central push. And then I also reduced the OZ and IC, so I brought it down to 6.0 and 6.6. And whenever working with flatter corneas, it's really hard to mold large areas. We always want to get a large zone for older patients so that they don't have any issues with glare at nighttime. But we run into the problem where the tissue mechanics just can't keep up, at least not with the current lenses we have. And we can get unusual optics in the within the visual axis. So for flatter corneas, I do go a little bit smaller, and that's mainly to give better quality optics. So I would attack the tear film first to make sure that's in really good shape, and then recheck the patient's vision. If we do need to make further lens changes, what I would propose is going to GSIM lens with a slightly smaller OZ, a little bit more demand, and then a slightly larger diameter. So Those are my thoughts on this case. I hope it helps, and you can apply the exact same things to the left eye. So best of luck and thanks for watching.